Welcome back to the Pediatric Speech Sister Show. I am so thankful and excited to have my good friend Rebecca here on the show. I'm going to let them introduce themselves. But Rebecca, I just had to bring you back on the show because, first of all, the moral injury episode that we did, I don't know if it was May or March, when it was last year, right? It was like a few months ago. And it's the top rated episode, like for the whole year for this podcast. And then I remember that you reached out to me and said that there were people talking to you about the episode. So I had to cut you off on our last episode because it was, there's just so much to talk about. So I wanted to bring you back on here just to continue the conversation and dive a bit deeper. Also, you go by Gender Affirming Voice on Instagram. So I felt like since I have you on this show, let me take advantage of your presence and ask you some more questions about that topic too.
Absolutely. Thank you so much. Thank you so much for having me back. I'm really excited to be here. I love your podcast. I love all your episodes. My name is Rebecca Von Duering. I'm a speech and language pathologist in the Puget Sound region. That's in the Pacific Northwest, specifically located in West Seattle. I am a clinical lead for Kaiser Permanente and also a private practice owner for Affirming Voice and Communication, PLLC. I go by they, them pronouns. Admittedly, I've started to professionally just say any pronouns because we'll get into that, the microaggressions of workplace environments. But yeah, I'm really excited to be here. I know that, you usually like to start your episodes with people's why. And, the way that I found the moral injury topic was that I was feeling pretty sad about work at one point, especially during the pandemic, and it really got amplified during the pandemic. We went through a lot of changes at work. Our appointment times got shorter. Our productivity requirements went up. We were having to switch over to telepractice, but without any real time to get good at telepractice or understand how to use the platform. And I was really finding it super difficult to provide the care that I felt like my patients deserved, and was finding that I was having less and less time to prepare for people. And it was starting to weigh really heavily on me. And I discovered moral injury of healthcare. And as I started to dig into that, I started to realize that speech pathology is another profession that gets hit by that. So I'm here to talk about that today. And I'm also really excited to talk about gender affirming voice care. Actually gender affirming voice care and moral injury go really well. They're, hand in hand go together, because moral injury is this idea that, the way that you provide your care is often impacted by factors that are outside of your control. And in gender affirming care, that's really prescient.
Oh my gosh. I'm just sitting here listening to you and I'm just thinking about the marriage or the science between gender affirming voice and moral injury. And so I'm excited to get into that in today's episode. Was there anything that changed about your why from our last episode since we've spoken?
Yeah, no, I wouldn't say. I mean, my why comes from my moral compass, and that's ultimately what moral injury is all about. It's that you have a moral compass that's being injured by factors outside of your control. And my moral compass is centered on justice and liberation work, and anti-racism work. And I really find that that to be truly trauma-informed provider, you really have to be doing that kind of work. And so, trauma-informed care has become more and more a topic of conversation and a topic of education in our field. And moral injury and trauma-informed care go hand in hand, because to be a good trauma-informed care provider, you really have to understand the socioeconomic and the adverse childhood effects of life events and people's experience that are impacting the person who shows up for care on any given day. And my why is, how can I provide the best care, the most equitable care, and the most competent care that I can provide, while acknowledging the intersectional identities of my clients and my own intersectional identities, and how those interact and shape the care that I'm providing.
Wow. Okay, so let me gather my thoughts, because a cajillion questions just popped up as soon as you were talking. So I'll start with the first one. We can just get right into it. How would you approach the intersections of even moral injury and culture responsive voice treatment for transgender communities?
Ooh, can you ask that question again, please?
Yeah. Let me see if I can reframe it. So moral injury and culture responsive care, right, for the transgender community. How do those two go hand in hand for speech pathologists?
Okay. So I think sometimes it might actually be really helpful to just go back and what is moral injury? So the definition of moral injury, it started in the 1970s, and it was in response to soldiers returning back from Vietnam War. And what was happening was they were experiencing events and behaviors in their leadership, and being expected to do things by their leadership during acts of war that were negatively impacting their health. So they were coming back, receiving PTSD treatment, and they weren't responding well to that treatment. And ultimately, the mental health providers working with them realized that, oh, this isn't actually a PTSD problem. This is a moral injury problem, and we have to attack this from a different perspective. And so they really needed to go in and get a good sense of what a person's moral compass is built around. And so when we think about these ideas about intersectional care and gender affirming work, so many people who want to go into gender affirming work are people who are either allies or members of the community. And when you're a good ally, you are aware of the social determinants that impact a person's ability to live their fullest lives, and depending on where you live, your client is going to have a very different experience. So in the state of Washington, we're a pretty small population as far as citizens in the state of Washington, but we're one of the highest for queer population. And that's because our politics and our laws are well set up to give people the best care that they can receive. Here in Washington State, we have something called the Healthcare Equitable Act or something like that. But it basically just says that any service that you provide to one population, you have to provide to all other populations. And so to be really, truly culturally competent, you have to engage with the communities that you're serving. And when you get good at that, you start to really hear the ways that that the societal influences are negatively impacting them, keeping them from showing up to work, to care, and being able to engage well in services on any given day. Regularly, I have probably about 10% of my caseload where I never know who's showing up that day. Is this a person who's ready to work, or is this a person who was bullied because of their voice recently? I have one person in particular in my caseload right now who I never know. I never know, A, if they're going to show up, or B, if they're going to show up ready to work. And so it's being really well engaged with understanding all the barriers that they're facing, and knowing how to interact with those barriers without letting those derail a session. I hope I answered your question.
You did. And I'm gonna follow up on that. But before I forget, what are some common pretty much just how are people from the transgender community negatively impacted so badly that they don't even want to show up to get the care that they need?
Well, so one person in particular I'm working with was recently made fun of because of her voice, and that was just it for her. So she shows up to services and can't do it that day. But sometimes it's less obvious. When we think about the systems that are in place, so we think about moral injury. Moral injury is the result of systems outside of your control. So those could be racist systems, those could be homophobic systems, transphobic systems, and something that I think about all the time in a large healthcare institution like the one that I work in is, what's their experience from start to finish with their appointment? So what's that experience that they have when they call to schedule their first appointment? Will they be getting misgendered on the phone during that very first phone call? Often they are getting misgendered because the system that's set up for the scheduling team does not include pronouns. So they have no way of knowing what a person's pronouns are. So instantly, right from the start, we don't always know if somebody's going to be gendered correctly. Then they show up for services and they need to use the restroom. And the restrooms that are located near my clinic are all gendered. And so they don't always feel safe to even use the restroom. So urinary tract infections are very common in my community, similarly to teachers. And so it's the bathroom experience. Then when they leave my session and they need to schedule more appointments, sometimes they'll call and they'll be scheduling appointments with me, and the scheduling team will misgender me. And then the patient will hear their provider being misgendered and think, oh, this is a system that doesn't respect the providers. And then from there, they might get home and receive a survey in the mail that dead names them. And dead naming is when a person is called by the name that was given to them at birth that they no longer identify with, and that dead naming is a microaggression, but it can also be a macroaggression.
Wow. Can you explain to us any other microaggressions that we might not even be aware that we're doing?
Oh.
I'm sure the list is endless, but I mean the main things that come to mind.
Well, actually, so in prep for this interview, I actually did do a little bit of research on the most common microaggressions. So it might be easier if I actually just read the list to you, because it's 12.
Please.
So there are 12 most common microaggressions in gender affirming or transgender experience. Those are use of transphobic or incorrectly gendered terminology. So that might look like, I had to call my retirement company the other day and they referred to me as ma'am. I interrupted and said, I'm sorry, I don't use the honorary ma'am. And then instantly I received the apology. I'm so sorry, ma'am. Oh! So we think about honoraries, ma'am, Mrs., Miss. I mean, even going to, I filled out a petition for disability rights just yesterday. And to be able to send that petition to my congressperson, I needed to select an honorary, and there was no affirming honorary, but I had to provide an honorary to send that petition in. So I had to choose. So I chose sir.
Yeah.
Another microaggression is assumption of the universal transgender experience. And we hear about this a lot in anti-racist work. It's that treatment of people as if they are a monolith, as if all people in that community have had the same experiences. But it's really realizing that, like, in the Seattle area, a lot of the transgender patients that I work with are well employed, have really strong finances, have some degree of family support, but that's not true for everyone. Seattle has a pretty high white population. It has a high tech population. And so because of that, we have higher incomes, and we just have better experiences. We also have a larger queer community here. And so because of that, people are affirmed more frequently in their experiences. Whereas if I were to go to Oklahoma, I would not expect to be affirmed, really. So that's that assumption of the universal transgender experience. Then there's the exoticization. And that's where you treat a transgender person as if they are exotic, as if there's something really special or interesting about them. And sometimes I receive inquiries from speech pathologists in the community who say, I'd really love to work with a transgender community. And my first thought is, why? Why? Why do you want to do that? Is it because you're an ally? Is it because you find it interesting? Is it because it's a really cool niche that you can say that you're a part of? And it really is understanding, like, there's that why question again. And the exoticization of transgender people, I think, does play a role sometimes when people enter the transgender or gender affirming work circles. Then there's discomfort or disapproval of the transgender experience. And that can just be something as simple as complaining about something that happened to me, and then having someone say, oh, that's not a big deal, when it was clearly a big deal for me because I said something about it. I just Little thumbs up there.
That's cool. Yeah, there's all these updates.
Thank you, AI. Well, no, and
Thank you.
it's actually really interesting. Speaking of microaggressions, the American Sign Language and Black American Sign Language communities talk about the way that the AI technology does things like that, where they're trying to say something like, I'm really sad, and the AI thinks that they're like celebratory because of the sign that they use to say that thing, and that looks celebratory. So that's an interesting microaggression we actually just saw there. So another one is endorsement of gender normative or binary culture or behaviors. This one's really important in gender affirming care. Endorsement of gender normative and binary culture or behaviors.
What does that look like?
So what does that look like? So that looks like referring to a voice as feminine, or saying, this is how women speak. This is how men speak. How can you replace that language in a way that's culturally sensitive? You can say things like, this might be perceived as feminine, or this is a feminine perceived behavior. Or you can even acknowledge the microaggressions of society and say, unfortunately, in our society, we have this binary that we're living in, and we want to be gendered correctly. And to do that, often we have to put ourselves in little boxes. And so my job here is to help you understand some of those boxes people are using and how you can put yourself in them or choose not to. And that's kind of a more culturally sensitive way to deal with that binary language. But in gender affirming care, it's a lot around the goals that you write. Like if you say that you want to, if the goal is actually written, will use feminine, then you need to understand why you're saying that. Because maybe if that's not your client's language, that's not what should be in your goal. So it's really important to really listen to the language that gets used by the person you're speaking with. There's the denial of existence of homophobia. There's the assumption of sexual pathology or abnormality. Similarly, like for me to receive any sort of gender affirming care whatsoever, I had to be given a medical diagnosis of transgender. I could not receive any sort of gender affirming care without first getting that diagnosis.
Wow.
Physical threat or harassment. Denial of individual transphobia, denial of bodily autonomy. This is asking inappropriate questions during your interview. Have you had any surgeries? Did you have the surgery?
Is that what we say? Have you seen speech
That's what
pathologists?
people get sometimes. Some people will get that. Sometimes there's that question in a voice evaluation. Have you ever had a surgery that might negatively impact your voice? That's the best way to ask that question.
Yeah.
Have you ever been in a motor vehicle accident that might have negatively impacted your voice? But there's the potential that somebody says, have you had any of the gender affirming surgeries? Are you going to have any of the gender affirming surgeries?
Because how does that help? How does that really help?
Yeah. Right.
Okay.
Right. It serves to other.
Mm-hmm.
We have two more. We have familial microaggressions, and that's the way that family can injure us. And then we have the systemic and environmental microaggressions. And like if you've been following my account on Gender Affirming Voice, you'll have seen that I've posted about the bathroom signage. A really great example of that is that on one of our department floors, we have all gender bathrooms. And at one point, I got very excited. The signage changed and it said all gender. And then 3 months later, they had taken that sign down and replaced it back with a male, female, gender neutral bathroom, or just bathroom, but male, female. And it had gone from gender or all gender back to this binary signage, which was really like, okay, so which bathroom do I use?
Why would you say? Yeah, why would they do that?
My understanding is that they didn't like the way the signs looked.
Okay.
And then what's happened now is that the person who was in charge of the signage has left the organization. So now everybody's wondering, like, okay, so was anybody put in charge of this signage project, or are we just back to square one again? We thought we were making progress, and now it feels like we're back at square one again. So that's that systemic and environmental microaggressions. So yeah,
Wow.
so those are the 12 microaggressions that are most commonly faced by the trans community.
I think, first of all, thank you so much for that education. All 12 of those, I felt very deeply. I mean, I could just imagine being a client and, of course, seeing their provider being misgendered or going to the bathroom and then seeing the male and female and just everything and how injuring that could be, how damaging that could be in receiving care. I did want to circle back because you did mention how you yourself had to go through a process of being medically diagnosed as transgender. Would you be open or comfortable with sharing how that process looks?
Well, I think it depends on the system that you're working within. So there's some systems are set up better than others. Some it really just depends on like how informed your providers are, whether or not they're members of the WPATH Association. WPATH stands for World Professional Health. World Professional Association for Transgender Health, and it provides standards of care that are offered ever so often. Every 4 or 5 years, they put out a new standard of care document. And so in my process, it was actually quite simple. I just mentioned to my doctor that I asked for a referral to the gender health program. I then got connected to a social worker. That social worker was then able to connect me with the services that are available under that insurance rider. And then I had access to the things that I needed. So, but it still requires a remarkable amount of care. Like I was placed under the gender, did I say care? I meant to say effort on my part. Because I was placed in the gender affirming program, but then it was still on me to change primary care providers and figure out who my primary care provider would be, as opposed to getting paneled easily. So there was still a lot of work around that, but I think that's acceptable. That's an acceptable
Okay.
level of effort, in my opinion, but some people might disagree.
Yeah, maybe a picking and choosing. Sure. Yeah. Well, I do want to get to three important questions that some of our audience members had. So the first one, and I wish I knew their name on here, but they really wanted to ask this. Any advice about being proactive on codifying positive legislation with their reps?
Oh yes. So, it's really about leveraging your allies, participating in organizations that are already involved. So knowing where to go, because you really shouldn't be out there trying to reinvent the wheel. There is most likely an organization that is already doing that work. So there's a lot of ways to get out there and to start participating in legislative action. But that's really where we come back to this idea of moral injury, because one of the biggest moral injuries that I've ever experienced was the Sandy Hook shooting, and that
Mhm.
had a really, really severe mental health impact on me. As a former teacher, it really I could just put myself in that school, and I could see those little kids, and I could feel those little kids in my heart, and it just broke my heart. And unfortunately, nothing has changed. There's been no legislative change. And so when we talk about moral injury, and maybe I'm a speech pathologist, itinerant staff that needs to go into 3 different schools, and I have to get metal detectors through this school, but not this school. I really start to think about, like, how did that happen? How did we get there? Um, so so that's where so many moral injuries come from, is seeing inaction from our legislators. But really, when you want to be a good advocate and put your beliefs in action, often it's using something called shared decision making. And that's really working with your patient, letting them know what all of their options are, understanding what might make them not want to choose particular options, and working with them on a healthcare plan or a speech plan or an OT plan that fits within their needs, and that's achievable for them. So shared decision making, and understanding that care delivery is political. So we have to engage in political activism. Teaching is political. Education is political. Healthcare is political. And you need to understand that you can't just be working in these systems and not doing anything. You can't just sit around and complain. There are things that you can do. You can be more or less involved, but you can do something. And so you can engage through, talking about things like what we're doing here, talking about moral injuries. You can call your political leaders. You can sign petitions. You can go to community health drives. You can participate in phone banking. You can engage in communities like volunteering for the Pride event, volunteering for transgender meetups. You can collaborate for change. And so I always just say, leave no stone unturned. Know who your allies are and leverage them. You never know who your allies will be. One of my strongest allies was the manager of dietary services. Was not expecting that, but that was one of the strongest allies I had discovered last year. So just talk, and you'll start finding the people who care about the things you care about.
I want to talk about allyship since you mentioned it. What was it that your manager did exactly that helped you feel safe?
This one's challenging.
Okay.
I have a very strong manager. I just want to start with that. I have a very strong manager. I don't always feel safe at work, and that's why that's a challenging question to answer. One of the challenges that I'm having right now is that over the course of 2023, I was harassed and confronted using the bathroom 3 times last year. And so in one event, I had a perceived cis male screaming down the hall that a man had been in the women's bathroom while I was walking away from it. That was very dangerous for me. I decided that I would wait until the 3rd event to ask for accommodations at work. And so I asked for a workplace accommodation to allow me time to go to an all-gender bathroom that's located on a different floor in the building. That has not been approved. And when I spoke with my manager about that, she was distraught and upset about it. But what made me feel most safe was that she didn't stick to just the fact that I was unsafe, but she really started to talk about the fact that my patients weren't safe. So she was able to understand that the problem I was experiencing went further, that it had more of a ripple effect than what I was just asking for. And so when she received no from the Disability Services Office, she went straight to safety, and she went to the safety department, and now she's working at the safety department. I suspect that she's not going to make progress. I suspect that we're going to be probably in the same place in a year from now. But I at least know that she understood that it was more than just going to the disability office, and that it was also understanding that we have a severe safety problem on our hands.
Wow. And you're right. She is very powerful. That's very powerful to even not just think about you, but also think about the people who you all are serving. So yes, hats off to her. Another question from our friend Claire. What is the best way to support transgender community in speech pathology, and how to build trust with the trans community as a representative of med institutions that perpetuate harm?
I think
We'll start with one question at a time. I'm sorry,
Yeah.
actually two.
Yeah. Well, so I think that I think I can merge them actually, because when I think about what we can do as healthcare providers, there really is a power differential that lies between the clinician and the patient or the client, and that can be for gender health, that could be for racial reasons, for linguistic reasons, for disability reasons. power differentials. So what can we do to create, to tear down those power differentials? One of my favorite things to say to clients is I say, I can offer you a safe environment, but I can't necessarily make you feel safe. What I can do today is I can work with you on making sure that the language that I use with you and in this report is reflective of you and is supportive of your needs and does not mischaracterize what we're working on today. So while I'm working with you and while I'm writing about you, I will let you know if I'm writing anything that you might not want to see in the chart, and I'll work with you on the wording just to make sure you feel safe. And that's just like a really basic, easy thing to do. Really, for me, allyship is what you do before. Allyship is what you do when you're by yourself.
Mm-hmm.
It's what you do when you're sitting down and you're setting up a template and you're adding your signature to the bottom of a template. And you know that you really should put your pronouns on your templates. You should put your pronouns in your emails. You should introduce yourself with your pronouns every single time. Because I have had colleagues say, why should I have to share my pronouns? You can look at me and tell that I'm female. And I'm like, that's funny. That's what people would say about me.
Mm-hmm.
So not quite. So it's understanding that because often, when we think about transgender folks in speech pathology, we're thinking about voice clients, but that's not true. I can't tell you the number of learning evaluations I've filled out or written where a 12-year-old that I'm working with uses they, them pronouns. And nowhere in the chart, nowhere in any medical record do I see they, them pronouns. But it's when I say, so I use they, them pronouns. I'm filling out a form about you right now. It's asking, are you a boy, a girl, or something else? And then I find out that, oh, they're non-binary or they're genderqueer or they're gender fluid. And okay, what pronoun should I be using for you today? I'd like to make sure that that I write about you in a safe and affirming way. And so, and I will actually tell you that in many conversations with other trans clinicians, they've actually told me that they're not always the most reliable about asking for pronouns either. And so it really is a practice. It's not the easiest thing to do. But I will say it's extremely othering when I have to do it myself. So when people who use binary she, her, he, him pronouns that are more anticipated by society, when they introduce themselves with that, it takes some of the pressure off, because often it feels like, oh, here I am making it the Rebecca show, as opposed to I'm just introducing myself.
Thank you so much. Thank you.
Mm-hmm.
What is a mindset shift that we can make as service providers when it does come to stepping outside of our comfort zones and introducing ourselves with our pronouns? And asking a student what their pronouns are.
Yeah, it's scary. It's not an easy thing, and it does feel different to add that to your care and to add that. Something that I did was I had on my backpack this bright red button that said they, them on it, and it was sitting behind my patient. So every time I looked up, I saw this. I was like, oh, I should do it. It's just this little reminder, because it's so easy to just be like, I'm not going to do it today. This person scares me. I'm not going to do it. They don't look, they're 82. They don't look like they're going to be tolerant to this thing. And I can't tell you how many times I thought, boy, I don't want to do this with this person. And then I'm like, I just got to do it. And I go and I say my pronouns, and they go, thank you so much. And then they tell me a story about someone that they love who's transgender. And, and it's the number of times I've been surprised. So I think a mindset shift is realizing that just because you're talking to a person that you don't think is part of the trans community, we have circles, we have networks, and someone in their network might be. And so it's remembering that when you use that kind of language, you're telling them that you accept anybody in their circle, anybody in their network, and that they can bring anybody they need to an appointment.
This was a very powerful conversation. Are there any resources, certifications, trainings that you would recommend to speech pathologists who are looking to be more culture responsive in this area?
I would I would send you to MedBridge, Winvestine and Leah Halou. I think I mispronounced some names, so I apologize about that. Wind uses they them pronouns, I think, and Leah uses she her pronouns. They have a really good MedBridge course. I highly recommend that one. It really asks you to do some work. And so I would always say that the best things that you can do is learn from the community. So if the training is done by all cisgender people, you should wonder about that. You should stop and think, why is that? Why is there no transgender person involved? We do have trans folks in the speech world who could be involved in this training. So why are they not? So really think about who's doing the training, and when you're involved in the training, think about yourself and think about the experience that you had. Because one of my big frustrations is when I'm sitting in a conference and then we get to the topic of gender affirming care or something, and all of a sudden they start talking about the participants in their study, and then they refer to their participants as AFAB or AMAB, and that stands for assigned female at birth or assigned male at birth. We're all assigned. Melanie, you were assigned. I was assigned. We were all assigned. So why are we only using that term to refer to transgender folks? That doesn't make any sense to me. We're all assigned. So if we're going to use language for one group, why are we not using that language for the other? So that's the kind of stuff that I like to think about when I'm sitting in a training and I'm listening to that. I want to be in a training that's encouraging me to think about my experience and and that experience that I bring to my care. And then also really having that idea that the people that they're talking about, they're not unique. This is not exoticism.
Right.
And so much in gender affirming care, so much of my work comes from stuttering therapy, comes from R articulation therapy, auditory bombardment. And so so when we just think about voice by itself, we're really not thinking about the whole client, because we have to think about how are we gonna get these things that we're working on today out into the world. And so I'm a co-director of a journal club called Forward Focus on Voice. We meet once a month. Follow us on Instagram. It's a great thing. And we're often talking about articles. So there's a really great article that was improving adherence to voice therapy. And it gives ideas about ways that you can improve adherence. One of the recommendations is that they found that people do best when they can see themselves performing well. They can see themselves having success. So they would learn better from a video that you take of them doing it than a video that you've taken of yourself doing it. So great advice. However, the gender affirming community often does have dysphoria around their body. So if you're going to take a recording of them or a video recording of them, find out what you're allowed to actually record. Should I just stop at the shoulders and only do your face? Does your face bother you? Can we just do the mouth? Can we just do an audio recording of you doing this thing? So really thinking about, like, there's a lot of barriers to care, and let's not let that be one of them.
Wow. Thank you so much, Rebecca. It's amazing that it's only been 37 minutes and you're able to pack all of that information in here. Is there anything else that you would like to share with us today, especially any changes that should be done in the field?
I think the biggest changes that need to be done in the field, I also recommend that you follow fix.slp on Instagram, fix.slp. They're doing a lot of work around really breaking down the ASHA criteria of having a certificate of clinical competence. You actually see that I signed on with MS-SLP, trying to just de-emphasize that need for the certificate of clinical competence that's being required of us, that's not being required of occupational therapists and physical therapists. They're not expected to join their national associations. And so it's this idea around, like, what is ASHA doing for us? Are they really fighting for us? Because I didn't want to lose when I came to meet with you today. I was really excited to talk about gender affirming care, but I didn't want to lose the idea of moral injury. And that moral injury is that things are happening outside of our control. You can be the perpetrator of an injury, you can be the victim of an injury, or you can be the observer of an injury. And so when I think about things that really get in the way, I think about, like, Okay, LSVT tells me that I need to do a 60-minute visit, that my visits have to be 60 minutes. Otherwise, I am removing, what is that, 15% of their care or whatever. Who knows that? Who knows
Mhm.
math? I'm a speech pathologist. But we're losing a good portion of their care. Is that 25%? But my appointments aren't 60 minutes long.
Mm.
So what do I do? So I'm having to do this mental calculus around, I want to give the best care. I want to give the care that's researched. I want to, this is what they researched, 60 minutes. They did not research 45 minutes. But so many of us only have 45-minute appointments. So what do we do? I think about my patients who are, they're going to leave my session and they're going to the food bank, and they were gainfully employed by the city of Seattle prior to getting cancer. And their entire savings got wiped out by their treatments. And they're like, I'm going to go to the food bank after this. And you're just like, are you serious? Like,
Mhm.
you got destroyed by this. And that's just
Mhm.
me being a witness to it. And then,
Mhm.
and then there's that perpetrator where, I'm a representative of my organization, and I ask my client, hey, did you check your after visit summary for your homework? And they go, oh, I don't read my notes, because every time I go into my notes, I get misgendered. So I don't go into my notes. I don't go into my chart. And that is
Mhm.
a serious access problem, that a person
Mhm.
does not want to read their medical documents because they will be injured reading it.
That's hard.
It's really
Finding
hard.
medical providers. And I'm also thinking about those are just the people who speak up about it.
Those are just the
Imagine
people,
the people who don't even say anything. Yeah.
exactly, because of that power differential. So how did I find out about that? Because I had already torn down the power differential. They knew that I was a safe person to tell that to.
Mm.
But then there's the racial inequities too. When we think about like kidney transplants and the way that I think it's kidney, but where the way that they do these calculations of who gets the transplant, and they add an extra point just for being African American, and that one extra point makes it that much more difficult to get the transplant.
Mm.
And there's no reason behind that extra point. Where I work, Kaiser has done a really good job of removing that extra point, but not everybody has. And that's when I say extra work. You do the work ahead of time. You figure out where are the gender neutral bathrooms, the all gender bathrooms. That way, when your patient shows up, you can tell them where to go. You're not
Mhm.
in the dark. Because I get scared now going to bathrooms. I get scared going places. I'm like, okay, I'm going to a restaurant. Is there going to be a bathroom? Okay. I need to go quickly.
Mm. Wow, Rebecca, I had no idea that this was your experience, so I really appreciate your vulnerability coming on the show, and I appreciate you teaching us a lot about the power of empathy when it comes to, I mean, really overall being a speech pathologist, but also preventing moral injury in ourselves and others. Where can we find you if we want to learn more about gender affirming voice, the amazing publications that you spoke about today, or have any other questions for you?
Well, so I will definitely share a link to the. I made a presentation for you for this
Oh,
talk.
you did. You're
Yep, so
wonderful.
I'll be sure to share the link to that, so anybody can go and look at the presentation and see some of the things that I talked about today. And find me on Gender Affirming Voice on Instagram. I'm also at Rebecca at affirmingvoice.com. That's my private practice account. And I'm always happy to take observers. So if you're in the Seattle area and you want to observe gender affirming care, I can usually find a good day where I have a lot of clients that are coming in that day, and you can watch a lot of different types of care, because it really is important to understand that no two people are alike, no two goals are alike, and that you have to treat the whole person when they come in.
Thank you so, so, so much, Rebecca. Well, thank you everyone for coming, and those watching the replay. Yes, please reach out to Rebecca if you do want to observe them. I'll probably be reaching out to you if there's a virtual option or if it's legal, since I'm not certified in Seattle or in Washington. We'll see. But everyone, thank you so much for coming on the show, and we'll see you next time. Bye, fam.